Periodontal Assessment Project by DavidiukA3. My patient, Bridget Stevens, is a 46-year-old Caucasian female. She is married, but they never wanted to have any children of their own. Her husband travels often for work, so most weekdays she finds herself home alone. She spends her days catching up on soap operas and talk shows, and enjoys spending her evenings drinking a glass of wine, or three, while smoking a joint of marijuana and binge-watching the latest Netflix series comfortably seated from her couch. Needless to say, she leads a very sedentary lifestyle. Bridget has been diagnosed with type 2 diabetes, which developed from her poor diet and sedentary lifestyle. She is currently taking metformin and sitagliptin for treatment. She has chosen to ignore the warning from her doctor to limit her alcohol intake while on metformin due to the increased risk of lactic acidosis. Since she doesn't fall under any of the other contraindications of having renal impairment, congestive heart failure, or being over age 80, and since she has not informed her doctor of her wine habit, the doctor is none the wiser and her prescription remains. Bridget didn't always smoke marijuana, but when she started experiencing nausea and vomiting as a side effect from her new medicine, a friend has suggested she give it a try. While it helps in reducing emesis, it hinders her diet plans, as she always has a huge case of the munchies afterwards. It also exacerbates the xerostomia she suffers from because of the diabetes. The sitagliptin, fortunately, has no effects on her oral cavity. When Bridget finally made an appointment for her routine cleaning, which she had been neglecting for the past 4 years, her probing depths of the periodontal assessment wrote a sad story. She presented generalized 5 to 6 millimeter pocketing and localized 7 to 8 millimeter pocketing, reflecting moderate periodontitis apparent in over 30% of her dentition, and advanced periodontitis localized to teeth number 18, 31, and 32. Bleeding, mobility, and furcations were also observed in her posterior regions of the mouth. As per the AAP periodontal classification, Bridget presents with non-plaque-induced gingivitis due to systemic illness, which is currently compounded by plaque-induced gingivitis. She also presents with generalized moderate chronic periodontitis with 3 to 4 millimeters of clinical attachment loss and localized severe chronic periodontitis of more than 5 millimeters of clinical attachment loss, both of which are in association to diabetes. She currently has a periodontal abscess on number 12 that is also present. According to the ADA classifications, Bridget presents with generalized bleeding and inflammation associated with gingivitis throughout her dentition. Moderate signs of periodontitis are generalized throughout her mouth to include recession and clinical attachment loss. Severe periodontitis is present localized to number 18, 31, and 32. Class 1 furcations are noted on number 1, 15, 16, 18, and 31, and Class 2 furcation is present on number 32. Mobility Class 1 is observed on all molars except number 3, while Class 2 mobility is present on number 32. Radiographic findings show 3 to 4 millimeter clinical attachment loss in 39% of the dentition and greater than 5 millimeters of clinical attachment loss in 9.6%. Vertical and horizontal bone loss are both present. Bridget's gingival description is as follows. Gingival color appears generalized, moderate to severe, dark pink and bright red diffused throughout the gingiva. Gingival contour presents as generalized, moderately rolled margins with bulbous and blunted papilla. Gingival consistency presents as generalized, moderate to severe, swollen, free gingiva. Gingival surface texture presents as generalized, severe, shiny, free gingiva with moderately fibrotic attached gingiva. Here we can see the three previous statements all put together for Bridget, a type 2 diabetic with a marijuana habit presenting with generalized ADA case type 3 moderate periodontitis and localized ADA case type 4 severe periodontitis. On the radiograph, we can see many indicators of ADA case type 3 moderate periodontitis. Both vertical and horizontal bone loss are present, with vertical bone loss most prominently showing at the mesial of number 14. There is a class 1 furcation on number 19 present, and on number 21 we can see that there is a 1-to-1 crown to root ratio. On number 18, the alveolar bone level is 5 to 6 millimeters below the CEJ on the mesial. In this image of the gingiva, the shiny rolled margins of the free gingiva is glaringly evident. The bright red to dark pink color is also clearly displayed throughout the gingiva. The papilla here on the facial aspect are bulbous, and the attached gingiva is moderately fibrotic, while recession is also apparent on several of the mandibular anteriors. This view of the lingual mandibular anteriors shows us a calculus ledge. You can also see the shiny rolled margins of the free gingiva, and the dark pink coloring is again present throughout the gingiva. Also, from this aspect, the papilla appear to be blunted. This picture, which was taken moments after probing the area, shows the bleeding throughout the mandibular left posterior region. It also captures the 8 mm pocket depth reading on the mesial of number 18. The blunted papilla are also apparent between the premolars and the molars. In this last gingival image, you can see a periodontal abscess above number 12. Stain can be noted on the mesial of number 11 from smoking, and recession is seen here as well. Both of her premolars in this area have previous amalgam restorations and signs of recurrent decay, which could potentially be related to the abscess. The prognosis for Bridget is fair to poor. Much of it depends on how well she responds to oral hygiene instruction and nutritional counseling. With the proper motivation, she could make a huge difference in her oral health and her diabetes management by discontinuing marijuana use, limiting alcohol intake, and improving her diet. Right now, she has a disease that is treated with medicine, with side effects that she treats with marijuana, which then leads to habits which worsen her disease. Unfortunately, if she does not make these changes, she will continue spiraling into a worsened diagnosis. For treatment planning, there are several codes I would use. Since she has not been to the dentist office in over 4 years, there is much work to do. A preliminary full mouth debridement, D4355, is necessary before a comprehensive exam, D0150, can be performed. Other codes I would use are D0140, D4341, D4910, and D1330. The flow of her appointment schedule is described in the next slide. At Bridget's first appointment, a full mouth debridement and a limited exam were performed. since a full exam was not able to be completed until after the preliminary debridement. Oral hygiene instruction was also given at her first appointment. Hopefully, Bridget will put what she learned into practice, and we will begin to see improvements by her next appointment. 2 weeks later, she came in for a comprehensive exam and a nutritional counseling, in addition to beginning the scaling and root planing of the right side of her mouth. As another 2 weeks pass, she can come back to finish the scaling and root planing on the left side of her mouth. Periochip was also inserted at this time to the pockets of number 18, number 31, and number 32. Her final appointment was another 3 weeks later, and those began her maintenance appointments. Here, the perio maintenance was done in addition to the topical fluoride application. These will continue every 3 months. At Bridget's first appointment, I chose to use an FSI 10 for the full mouth debridement and the beaver tail for removal of the calculus ledge. When it was time to begin the SRP, I started with the FSI Slimline 1000 and used the After 5 left and right for the posterior areas. After Cavitron use, I used the Keaton for furcation areas and the Nevi 1 for the anterior region where the sulci were shallow. To fine scale and root plane, I utilized the After 5 Mini Gracie curette along with the Anna Pattison maintenance curettes. For home care recommendations, Periodex was prescribed. I also highly recommended Bridget use a water flosser to aid in the removal of plaque and biofilm in the deeper pocketed areas. Chewing xylitol gum will be a huge help to reduce the dry mouth caused by her diabetes and metformin. For brushing, I taught her the Stillman technique and ensured she knew to brush a minimum of twice a day. I encouraged her to use the Crest Oral-B electric toothbrush to help her maintain the full 2 minutes of brushing. I recommended Crest Pro Health toothpaste since it has stannous fluoride, which has antibacterial benefits, and this is a plus for her since she is also diabetic. To floss, I recommended she used waxed floss as it's easier for her to slide it between her contacts, as I was concerned about patient compliance. For mouth rinse, I advised her to use Listerine Zero in addition to brushing and flossing, and Biotine rinse to be used as needed for xerostomia. For fluoride, in addition to the recommended fluoride toothpaste, Bridget will be coming in once every 3 months for a fluoride varnish application in the office. Nutrition is very important for Bridget, as it will be key in not only improving her oral health, but in combating her diabetes as well. She needs to add fresh fruits instead of canned fruits and syrup, non-starchy vegetables instead of corn and potatoes, white meat like turkey and fish, and not processed deli meat or hot dogs, and non-fat Greek yogurt instead of whole-fat dairy. She should also add whole grains, avocados, almonds, and pecans for a balanced diet. She should omit marijuana and limit calories from saturated fat to 10% of her total daily intake. Alcohol should also be avoided. Supplements that would benefit Bridget are vitamin B to help prevent against diabetic neuropathy, vitamin D to help boost production of antimicrobial peptides, and omega-3 fatty acids to decrease the rate of heart disease since diabetics are at an increased risk.